This session is on deformity, and I'm going to start things off and talk about some principles in adult spine deformity. Jaron will then talk about adolescent and pediatric deformity, and then Justin will discuss the issues of alignment, followed by Matt, who will tell us when to operate on pediatric patients. Can I get my slides up there? So this quote was emphasized heavily during my training, and over the years I've tried to keep it in mind. We need to study and learn principles and not get locked down on methods. The interesting thing about this has been incorrectly attributed to Ralph Waldo Emerson, where in fact it actually belongs to Harrington Emerson, who was a fairly well-known engineer and efficiency expert in New York in the early 1900s. Don't ask me why I spent the time researching this, but I thought it was interesting. So spinal deformity in the adult is an increasingly common disorder with significant and measurable impact on HRQL. Despite advances in our technology and surgical techniques, the surgical treatment is still complex with significant risk of complications. Quite simply, the definition is malalignment of the spine. It can be segmental, regional, global, or typically a combination. Now, I'm not going to say much about alignment because Justin's going to tell us all about that, but it's worth mentioning that alignment is critical for the maintenance of an upright posture, the stability of the axial skeleton, and for minimal muscular energy expenditure. Adult spinal deformity consists of scoliosis, sagittal malalignment, kyphosis, spondylolisthesis, and axial plane deformity. Scoliosis can be a sequelae of childhood deformity or can occur de novo during adulthood secondary to degenerative disease. Other causes of adult spinal deformity include trauma, tumor infection, inflammatory conditions, and the all-important post-surgical or iatrogenic deformity. Post-surgical adult deformity can occur as a result of either destabilization, i.e. multiple laminectomies, or from malalignment. The prevalence of adult spinal deformity is reported to be as high as 32% in the general population. Most studies would suggest it's somewhere in the neighborhood of 15% or so. But it's also reported to be up to 68% in people over 65. And with our population growth and the number of older adults with adult spinal deformity, it's estimated that there will be more than 60 million by 2050. So this puts a growing strain on our resources, making it very important that we develop evidence-based approaches. If we don't, policymakers and third-party payers will. So before we talk about indications for surgery in the adult, first of all, we have to ask ourselves, should we be operating on adult spinal deformity? Well, we know that there is significant impact. Adult deformity has a measurable effect on physical and mental health with back pain, neurologic symptoms, difficulty standing upright, and functional limitations. It results in a marked disability when compared to the general population, and the disability with adult deformity is comparable to that folks have with diabetes or rheumatoid arthritis. So there's significant impact, and the impact worsens with age. We also know that the operative treatment of adult deformity does result in improved function and health status, as well as reduced pain. And furthermore, despite a higher complication rate, the elderly tend to gain a disproportionately greater improvement in their disability and pain. That's because they start out worse, is the primary reason for that. So the indications for surgery in adult deformity are not as clear-cut as they would be for an adolescent idiopathic scoliosis, which is typically related to curve magnitude or progression. The adults more often seek care for pain and disability due to degenerative disease and malalignment. And curve magnitude may not be the major issue in adult deformity. Other differences between adult deformity and the adolescent are having to deal with comorbidities, issues of bone quality, stiffness, sagittal malalignment, the need for neurologic decompression in many patients, and the frequent need for fusion to the sacrum. Sig has written about this. There's such a wide variability in the indications, surgical technique, and post-op care that it's very difficult to develop appropriate use criteria for adult scoliosis surgery and still be responsive to these variables. Here's an example. This is a 56-year-old physician, female physician, had adolescent idiopathic scoliosis as a child, basically lived a normal life, normal adulthood, but over the last several years has developed progressive pain and has had documented progression of her scoliosis. She's healthy, she exercises regularly, she's a non-smoker, does not use narcotics. Here she is recently at 4 years post-op. We had no surgical complications. She's continuing to work full-time as a pediatric oncologist and has minimal pain. So if all of our patients were like this, our meetings would be pretty short and pretty boring. But on the other hand, this is a 70-year-old female with severe back and lower extremity pain. She has a documented progression of her curve, lumbar stenosis, osteopenia, hypertension. She's deconditioned and takes hydrocodone daily. So this patient has a totally different risk profile than the first. And our goal here would be to optimize her, try to get her as close to that first patient as we can. So have not operated on her. She's currently on a 1-year course of Forteo. She's on a daily walking program and is weaning from her narcotics. So the principle here, I think, is that surgical indications and goals may not be the same for all patients with adult spinal deformity. These indications vary depending on risk stratification, patient expectations and desires, and shared decision-making. So another example, a 63-year-old lady with long-standing back and lower extremity pain who has had extensive conservative treatment without relief and ultimately undergoes this procedure. She's now 2 years post-op, T4 to S1 with interbody fusions at 4.5 and 5.1. She has some upper back pain and in retrospect, could argue probably should have gone to T2 instead of T4. She has no lower extremity symptoms. She's happy continuing to work as a teacher. Here's a patient with a similar curve pattern, not much back pain. Her primary complaint is right lower extremity pain, primarily related to her foraminal stenosis, as you can see here, related to her asymmetric collapse at her fractional curve. She doesn't want a big scoliosis operation. She just wants to get rid of her leg pain. So in this case, we just did a single level decompression and fusion, and here she is 6 months post-op, happy with no leg pain and no back pain. Obviously, there's some risk for junctional pathology here, but she understands that. And she's willing to accept that risk and not have a big scoliosis operation. And before we get into specific indications, just a brief word about non-surgical treatment for adult spinal deformity. To date, there's no solid evidence that non-operative treatment for adult spinal deformity results in any improvement in health-related quality of life. Yet it accounts for the largest component of increased costs over the past decade. We all still do it. And again, just another reason we need evidence-based pathways in the treatment of adult deformity. So for thoracic curves in the adult, what are the indications? Well, first of all, very few adults actually seek surgical treatment for isolated thoracic scoliosis as opposed to the adolescent. And typically those adults are young adults with significant curves and concern for self-image. But in general, we know that thoracic curves over 50 degrees tend to progress, and they can be considered for surgery depending on the patient's symptoms and concern for the deformity. On the other hand, if symptoms are manageable, the patient can be observed for progression. Selective thoracic fusion can be considered in the adult. Typically, that's going to be the younger adult without significant lumbar pathology. Here's an example where I probably pushed the envelope a little bit. 50-year-old female with progressive thoracic curve and thoracic back pain, no back pain despite radiographic evidence of degenerative disease. So did a selective thoracic fusion from T2 to 12, and then here she is at 4 months post-op with distal implant failure and distal junctional kyphosis. Now, admittedly, today we would have had much better fixation distally than we had then, but she was revised to L1 and subsequently did well for many years. I recently saw her for a 14-year follow-up, and she reports that she's had about a 3-year history of back pain and lower extremity radicular pain. She had seen another physician and undergone a laminectomy or hemilaminectomy without relief, and is now considering extension of her fusion to the sacrum. So she got to use her lumbar spine for 14 years. Was it worth doing this? Only she knows. The majority of adult deformity patients seeking care have lumbar or thoracolumbar curves. And again, the degree of curvature is not as important. Surgery would typically be indicated for curves that are progressive, those with severe back and or lower extremity symptoms unresponsive to non-operative care, those with neurologic involvement, or with symptomatic sagittal malalignment. So here's an example. This patient has back pain, bilateral lower extremity symptoms. She's had 3 prior lumbar surgeries, including an L5-S1 fusion. She's developed severe recurrent stenosis at L4-5. Multiple long-term conservative treatments that have not helped with her symptoms. And here she is at a year post-op, revision laminectomies, interbody fusions at 3, 4, and 4, 5, and an instrumented fusion to S1. No iliac screws were needed because she had a solid L5-S1 fusion. And currently she's doing reasonably well with no lower extremity symptoms, mild to moderate back pain and off narcotics. Most adults with symptomatic lumbar and thoracolumbar curves have lumbosacral pathology, and therefore most will require fusion to the sacrum. It can be avoided in selected younger patients who have, quote, healthy L4-5 and L5-S1 discs, but I think those are few and far between. And you also should know that if you elect to fuse to L5, you run a very high risk of developing distal junctional pathology. So our goals of surgical treatment of adult spinal deformity are reduction of pain and disability, safety, and cost effectiveness. Reduction of pain and disability occurs when you can restore alignment, decompress neural elements as needed, and maintain alignment. We maintain alignment with stable fixation, obtaining a solid fusion, and avoiding junctional pathology. Easier said than done. Obviously, patient safety is important, and it's intertwined in every aspect of adult deformity surgery, including patient selection, preoperative optimization, surgical planning, surgical technique and skills, postoperative care, and the management of complications. And just an example to illustrate that. Here's a patient I saw fairly recently, 50-year-old female, scoliosis since childhood, really no prior treatment, been living with it, never even been to a doctor about her scoliosis until recently. She's developed back pain, but primarily right lower rib pain where her ribs are impinging on the pelvis. She has occasional shortness of breath. And if you can look on the lateral, you know you've got a pretty severe deformity when you have an axial view of the vertebra on the lateral view. So you look at this and you're thinking, okay, this is a big deal. It's multiple osteotomies, possible VCR, lots of blood, big risk of complications. But not necessarily required that you have to do all that stuff, although I'm certainly prepared to do it if necessary. But in this patient, I just did a T2 to sacrum fusion, no osteotomies, although I did facetectomies at every level. And here she is. She's not that far out. She's only about 3 or 4 months post-op, but you can see that she's reasonably well aligned. Her trunk was lengthened 6.5 centimeters, and she's happy with the way she looks. And this was able to be done, relatively safely. So in conclusion, adult spinal deformity has significant impact on health. The prevalence of adult deformity is going to continue to increase with our aging and increasing population. We have ample evidence that surgical treatment of adult spinal deformity improves health-related quality of life. There's a wide variability in surgical indications. There's a direct correlation between radiographic parameters and self-reported pain and disability, with sagittal alignment being the most important. And finally, the current economics in the treatment of adult spinal deformity are not sustainable. Thank you.